Okay.
Hi, Nicole. How are you?
Good. How are you?
Good, thanks. So, yeah, so this is our second attempt. We recorded this already, and unfortunately, it's completely my fault. I messed up. I pushed the wrong button and didn't record. But I
That's it.
right away took a bunch of notes on everything we talked about.
Oh, good. All right.
So,
Maybe we'll be better.
um,
We'll do a better job this time. Let's see.
yeah,
Yeah.
yeah, Nicole Lamberson, you are in charge of the BIC or BIC, Benzodiazepine Information Coalition.
Mhm.
And yeah, for anyone who doesn't know what that is, tell us about what exactly the BIC does.
Yeah. So it's a 501(c)(3) nonprofit in the United States that was founded in the summer of 2016 by actually injured patients who were injured by benzodiazepines. And they brought on medical professionals and other professionals like therapists to form a medical board for the nonprofit, essentially to raise awareness and educate about the adverse effects of benzodiazepines, specifically when taken as prescribed. So we don't do a lot around benzodiazepine misuse, abuse, and addiction, just mostly around the prescribed physical dependence problem.
Yeah. And if you go to the homepage, I believe it has the percentages of, and one of them that really stands out is what the chance of a person being addicted is. And I think it's a tiny percent. Like, is it 1% or less than 1%?
Yeah, so that study was done by the National Survey on Drug Use and Health. I think well, they took the results from that survey. It was like a 2015, 2016 survey, and it was 100,000 adults 18 and up. And among US adults, they determined 12.5% used benzos, but only 1.5% um, who were benzo users had a use disorder or addiction. So basically, the summary of that study is that while benzodiazepine use is high, um, use disorders or true addiction is actually pretty rare. And I don't think that's something that a lot of medical professionals appreciate or understand. You know, they hear about benzos causing withdrawal, or even the word withdrawal sort of sparks the idea of addiction or substance use disorder in people's heads. But what we find most people are missing is that they just don't understand the difference between prescribed physical dependence and addiction or substance use disorder, and that withdrawal does not equal addict or addicted by definition. You can have a withdrawal syndrome just by way of taking the drugs on a daily basis exactly as prescribed by your physician. So we get tons of reports all the time from patients who are struggling to get off their benzodiazepines, and they are panicked because their doctor suddenly, kind of freaks out on them and says, "Oh, if you're having trouble stopping, I'm going to stop prescribing the drug for you because you are addicted or having a substance use disorder issue." And that's the wrong thing to do. People in that position need repeat prescriptions of benzos in many different forms, smaller doses, liquids, in order to do a really long outpatient deprescribing protocol, like a taper at home, essentially, to get off safely. So
Yeah.
that's why we differentiate. I mean, that's been one of our like main projects at BIC, is to really try to define the language so that misunderstanding in language is really understood, so that patients stop being harmed by that.
Yeah.
Yeah.
Yeah. Doctors really don't know a lot about addiction from their training. And that's something that in the addiction treatment world, they talk about, that it's one of the biggest problems that we have is addiction, and we know, which is clear with all the news about fentanyl. It's a major problem, and it's something that, if anything, doctors might get, an hour or two of lectures in medical school, there's very little coverage of addiction. And one important thing about learning about addiction, and I think a lot of people who are addiction specialists don't understand this even, is to know when something is not addiction. Something might look like addiction to your average person, but it's not. And so when doctors don't understand something and they don't know about it, they fall back on what they think they know, probably from their regular life. I mean, I don't know, maybe what they see on TV, what their family and friends and upbringing has taught them. And they see someone in a physical state of withdrawal, shivering, shaking, upset, anxious, agitated, saying, please help me, I need something right now. If you just give me that pill, I'll probably feel better. That looks like addiction, and it's not addiction always. It depends.
Mm-hmm.
And there's things that cause addiction and physical dependence. There's things that cause only physical dependence, and there's things that have more addiction and less physical dependence. And also, I think it's confusing because benzodiazepines are intoxicating. If a person takes too much, they might look like they're drunk. And alcohol is addicting. Alcohol has physical dependence and addiction.
Mm-hmm.
So I can see that a doctor or family members might say, well, it kind of looks like, and to even confuse it further, people in the addiction world might say, well, benzos are like alcohol in a pill. I think I've heard that for more than once. And they're really not. They don't have that addictive component. They can be intoxicating, they can be misused and abused by people, but they don't call addiction. It's hard to define. It's not. There's a lot of different definitions for addiction, but one easy way to look at it is a person who's addicted to a prescription medication is probably going to use it all up in a very short time. Mm-hmm. If someone's addicted to their opioid prescription, the whole bottle will probably be gone in less than a week. People that take their benzodiazepines as directed, they still have their bottle full, or they still have their medication left appropriately because they take it as directed. If a person can take their medication as directed and not keep taking extra, they're probably not addicted. In some cases, even if they take a little bit too much, still doesn't necessarily mean there's an addiction. But it's really important because when people confuse addiction and dependence, when they think that if family members think that their loved one is addicted, they send them to the wrong places. They're like, you need to go to rehab. We need to get you off this stuff. You need to be detoxed quickly, which is completely the wrong way to treat benzodependence.
Yeah. I mean, it can be catastrophic. That's what happened to me. I went to a detox center because I didn't know how to get off of this stuff. And nobody told me that, oh, what you have is a physical dependence and not an addiction, other than my father, who's an anesthesiologist, kind of figured it out and sent me these articles while I was in this rehab center, being accused of being an addict. But like you said, I showed up there with a whole bottle of Klonopin and like all my polypharmacy and was like, I just want to get off of this stuff, and they didn't know the difference. And it makes me think of that old saying, like, when all you have is a hammer, everything looks like a nail, right? So anybody who walks through the door of a rehab center, like all they have is this hammer. So you're gonna be a nail. You're gonna be an addict because they don't know anything different. They don't know how to treat any differently, or the place isn't set up for what I needed, which was outpatient tapering. So they subjected me to 12-step stuff, which was totally irrelevant to my situation, and ripped me rapidly off of all of the drugs that they deemed quote unquote addictive, even though I hadn't been misusing or abusing them at all, and put me in a severe withdrawal syndrome that horribly damaged my nervous system for years. I mean, it was a very, very protracted syndrome. And that, to give you some perspective, that happened on October 10th of 2010. And it is 2024, and I still have symptoms of nervous system injury from being detoxed in that manner. So, yeah, I mean, you can steal years and years of life and health from somebody by subjecting them to the wrong treatment. So that's why we advocate around the language so much, so that people really understand the concept. the other thing that you touched on, I mean, I wonder, have you worked with both patients in your practice, people who are truly just physically dependent to benzos, and maybe somebody who actually had a benzodiazepine addiction by, that could have been diagnosed as such or like met the criteria? I've worked with both, and to me, it is like just blatantly obvious like the difference in people.
Yeah,
Uh, the people who are purely physically dependent, actually, sometimes some of the work with them is trying to slow them down in coming off of the medication because they want it out of their body. They're begging you, please, please, can I taper faster? Can I? And that is not typical addict behavior. So to me, I can't believe that people can't like see the differences in people, but maybe it's because they aren't working with people like with an open mind when these patients come in, and knowing what they're looking for. If you don't know what you're looking for, you can't accurately diagnose it. So,
yeah, yeah. It's benzodiazepine dependence is very different from and I don't even know that the rehabs are even handling things like alcohol and opioids. I mean, for a long time they were mishandling opioid addiction
mhm,
and dependence also, because opioids cause both addiction and dependence. Because we have, for the last 20 something years, and even further back if you count methadone, but we've had Suboxone or buprenorphine for the opioid patients, and the rehabs were all very resistant. They said, if anything, we're going to use it for a 1 or 2 week detox, but nobody should be on this medication long term. But buprenorphine, which is Suboxone, allows us to do long-term tapers off of opioids, similar to benzodiazepines. We can take 1 to 3 years. We can take a long period of time and let the person really get used to a gradual taper and stabilize. And these rehabs, exactly, they have that one hammer that really doesn't work very well on anything, and
mhm.
everything is a nail, and they just don't want to hear anything different. I mean, we have like a whole Home Depot full of all kinds of different tools, and they're like, we're happy with our hammer, and
Yeah.
it's really not
And the
good, but
success rate is something, I mean, I don't know. I don't know if you've seen the documentary, like I think it's called The Business of Recovery. Have you seen that one? It's pretty
no, I
sad.
haven't
I
seen that
think
one.
like they say that the rates of success are like 5% or something like that of those places.
Yeah,
Oh,
and I think that's true, and I think it's also similar to the spontaneous success rate of people that would just get better anyway without any help, because there are always a certain number of people that even with addiction, there's people that grow out of it. They get tired of it. They realize on their own, and not everybody. I mean, no one should feel bad if they can't get in that state of just saying, "Okay, I'm done with it." But that does happen. There's a percentage of people that are addicted, and they're just like, okay, I've had enough cocaine. I'm kind of tired of it, like losing everything in my life. I'm done with it, and they would probably have gotten better anyway. So,
mhm,
when they count, when you go to like, just for example, if someone goes to like an AA meeting or an NA meeting, Alcoholics Anonymous, and they see all these people that have all these years of success, like people raising their hands saying, I've got 30 years sober, 20 years sober. Um, those are the few people that, for whatever reason, it worked for them. Maybe they like to sit in a room and talk for whatever reason. But you don't see the thousands and thousands of people that came and went and found some other solution, or maybe nothing worked for them. So it's a, a selection bias. It's that we only see the success rates, and rehabs will point to that. They'll say, well, oh, look, we look at all these people that have had great success. I think even with which is interesting with the opioids, there's a lot of people on opioids that are only physically dependent, not addicted.
mhm,
And I think a lot of those people think they're addicted, or they thought they were addicted years ago, and maybe they got in recovery and they got over their physical dependence, and maybe there never really was an addiction, and so that would look like a success rate in addiction treatment.
mhm.
um, so yeah, I think there's a lot of confusion with that.
Yeah. Or they don't follow up. Like I left that horrible place free of the drugs they deemed addictive, but I never went back there to tell them, like, hey, you imploded my nervous system. And I actually had to go back on benzos by a psychiatrist who knew what she was doing, you know? they don't know when you leave, because a lot of people figure it out after the fact, and they're not going to report back to this rehab place, because what, I mean, that place can't do anything for you. So you just move on and find treatment that makes sense, essentially. So maybe they
Yeah,
have next to my name, oh, we got her off. Well, you didn't. You actually destroyed my nervous system. Um,
yeah,
so
yeah. It's true. If they count their success rate as that you walk out the door not taking benzodiazepines, and they would count you as a success, and they harmed you. That's iatrogenic harm,
yeah.
medically induced harm.
Hmm.
They were complicit and damaging your nervous system for many years. And no, and they're also, if if someone's looking for help and they go on Google and search for how do I get off of benzodiazepines, the top search results are all going to be rehab or detox facilities, like places that are going to do that.
Yeah.
Um, I mean, look, I guess Google is now, like, for a long time now, they usually put like the official, like, SAMHSA government thing at the top of, that these advertisers don't get to come out above that. But I don't even know if that organization, I don't know if SAMHSA, I think it's SMA, whatever it is, SHA, that, the organization that deals with, part of what they deal with is addiction. But I don't even know if they differentiate, and would help someone in that situation. For all I know, maybe they just send them to rehab. But yeah,
Yeah.
it's difficult. I mean, are there like a lot of experts or science, like, that people can look to learn more about, like, how this works, like why tapering has to be done very gradually?
I mean, the Ashton manual was kind of like the old school, like landmark document that existed since the 90s, when she had a clinic over in the UK where she worked with patients to withdraw them slowly. And then she wrote the manual based on her experience with those patients.
Yeah,
Um, so that's kind of the first document that exists that explains this. Although she didn't go into the difference in language, the difference between physical dependence and addiction in that document. And I think she used um, addiction language incorrectly
yeah,
in that document. So now we have, as of this year, the Maudsley deprescribing guidelines that were just released. And that the authors of that are Mark Horowitz, who's a psychiatrist in training in the UK, and Dr. David Taylor, who I believe is a psychopharmacologist who's well known in the UK for his work. And Maudsley is a very respected textbook in the UK. The textbooks by Maudsley prior to this one are all called Maudsley prescribing guidelines. So it's all for psychiatrists and doctors about how to prescribe psychiatric meds. So the latest one is the deprescribing, Maudsley deprescribing guidelines. It's the first of its kind, and it's incredibly detailed and thorough, because Mark, who is one of the co-authors, is a psychiatrist in training, but he's also a patient. And I've heard him say he considers himself a patient first because of what happened to him trying to withdraw from psychiatric medications, including benzos and sleeping pills that he was on. And so he's written an incredibly thorough textbook about all the different ways that people are tapering these drugs at home on their own. And he had contributors to the book. I helped with the benzo section. Dr. Christy Huff, who's passed away, but was our medical director at BIC, also helped. Um, and I think he has in there, gabapentin, Z drugs, benzodiazepines, antidepressants, everything that needs to be tapered slowly at home on an outpatient basis. So this can be bought, and you can take it to your physician if you're a patient out there and you find yourself in this physical dependent state and having trouble withdrawing. You can educate yourself with it, but you can also take it to your doctor or PA or nurse practitioner and use it as a tool to sort of convince them, like, hey, this is a well-respected textbook with all the information that we need to safely get me off of this stuff. at home in the way that it's supposed to be done. So that doesn't mean you're guaranteed to have still an open-minded clinician who's going to read it and listen to you, but it at least it's sort of a tool in your toolkit to try to be better understood and taken seriously when you walk in there. So
Yeah,
yeah.
that's a good point. That kind of reminds me of I I remember hearing in a lecture that if you have a if someone has a legal problem, they're going to a lawyer, that you expect your lawyer is going to handle your case, and the truth is um, that you need a an expert witness or an advocate, and they say that you're your own best expert witness. Oh, sorry, just declining a call there. That you can't expect a lawyer to handle your issue. You need to be your own expert witness. You need to get deep in the case and review everything and act like you're your own lawyer and learn everything, and kind of put it together and package it up in a way that can be easily understood, and say, this is what my real case is here. That you do need the professional, but you need to be your own best advocate and really educate yourself. And it's not just true for working with a lawyer, it's true for working with a doctor. That if you go to see a doctor that only has 15 minutes to see you, and they're in a hurry and they've got 50 people on the schedule for that day, if you walk in and say, I need to taper, I need you to prescribe me this liquid compound, and I'm going to take a little bit less on a regular basis and follow this tapering schedule, that might work. Or they might say, like, where'd you get this from? On Google, and then they say, like, you can't go to Dr. Google, listen to me.
Mm-hmm.
And then the next thing you do, if you bring in this book and say, here's this deprescribing guide, written by scientists and experts in the field, and this is real science, this is a real medical textbook. And if you say, I've read it through for you because I know you don't have time to read it, and I've put together a plan, and this is going to work. And if you want to read the book, you can. Having that authority, and also having done some of the work, and that can, I think that can go a long way. Like that we really need to be our best advocates, or even to have somebody with us, to bring somebody to an appointment that can stand up for you. Maybe a spouse or a parent or a family member. Somebody. It helps if you have somebody that has some medical knowledge, and or that can, but to not to fight the doctor, but to say, like, I know you're in a hurry and that you don't know a lot about this, maybe, which is understandable, because nobody teaches this stuff. It's anti-big pharma, which unfortunately the medical education system has big pharma is so deeply entrenched. That's probably a big reason why there's no science about this stuff, or not much science. Of course, in the UK, things are different, but definitely in the US, our medical education system is so infiltrated by these drug companies that have no intention of anybody ever getting off of these drugs. But so if a patient can go being their best advocate, and maybe bring somebody with them to advocate for them, and they have also this medical book that has all the information in it, and you've also put together a plan. I think people can possibly, in a lot of cases, make things work with their primary care doctor or their family doctor.
Yeah, totally. I mean, one of the number one emails we get is, at Benzo Info Coalition, we have a doctor's list that has physicians, you're on there, who are willing to help people taper benzodiazepines. But we have above the list is a huge disclaimer that says, just because somebody's on this list does not mean that they're super educated on proper benzodiazepine tapering. Like, at best, what you're probably going to get is a collaborative physician, PA, nurse practitioner, who's willing to prescribe you the drug, but they may not know all of the tips and tricks and things in the Maudsley book or in the online forums that you can learn for yourself. And so people will write us and say, well, I went to this doctor and they didn't like design me a micro taper. And it's like, well, they're probably not going to. You're going to have to figure that out yourself with a coach who knows how to do that, or in some of the groups, you can read, and in the Maudsley book, you can read. So yeah, it's unfortunate that you have to like dive deep into a textbook and learn how to save yourself from this situation, but it's just reality, unfortunately, with the landscape of our, this gap in like medical knowledge that currently exists. You're just going to have to do that unless you are one of the rare few that is incredibly lucky that, you know, comes across you, Dr. Leeds, or lives in the state where you're licensed, or, you know, maybe Joseph Witt-Deering in the few states that he's licensed in. I mean, there's a handful of physicians who are like top of this field and could manage a taper for you in that way, but most of them are not going to have any idea, and so you're going to have to be the one who drives, you know, this, and then your physician or uh, prescribers just kind of like your co-pilot essentially along for the ride, and maybe they learn from you. You know, I've had tons learn from me, and then they can take it forward to their next patients, you know, and do better next time. But yeah, you may just be getting somebody who has no idea what they're doing, and they're kind of relying on you to tell them what you want to do. In other cases, we've even had patients who had to lie in order to save themselves and say, the drug is working really well for me. I'd like to keep taking it, because they feared if they mentioned that they were trying to withdraw, that the patient would try to take over. I mean, the doctor would try to take over. And that happens all the time. I don't know why. I don't know if it's an ego thing with physicians or a control thing or what. But as soon as you mention taper, they start saying to patients like, "Oh, all right, well, you can do it in a month. Cut it in half again, and you'll be done." And when the patient says no, then they're like, "Well, that's how we're doing it," you know? And so some people are just terrified to even bring it up in the first place because they kind of know the vibe of their doctor. They don't feel like they're going to be collaborative. So they just pretend like the drug is working great. And then they go home and read Maudsley themselves or hire a taper coach or something and devise a plan. And then they just do it on their own behind the scenes. And then once they're off the drug, they just like never go back to the doctor, you know? So that's the least ideal way. Obviously, we'd like everybody to have somebody monitoring them who cares about them and wants to know that they're okay and who's like on board with the plan. But again, that's not reality in all cases. So, yeah.
Yeah. Yeah, I think that's part of medical education that, and I don't know if it's intentional or not, but that it works out that way, that, you know, desensitizing the doctors, kind of dehumanizing them. And it starts with things like, you know, for example, they have a lab where you have to learn how to do surgery. I don't know if they do this anymore, but you have to do surgery on dogs. And we had that lab, and I had this idea that I thought, like, if we're successful, if we save our dog, if we do all the surgical procedures we have to do, and our dog survives, you know, he's going to get to go, you know, live on a dog farm or something, you know, retire somewhere. Like he survived because we did our job. Well, I didn't realize none of the dogs make it, whether they survive the surgery or not. In fact, this is, maybe I shouldn't say this is horrible. There was this barbecue smell one day, and someone told me that's the dogs being what do they call it?
Like
You know, like when they,
incinerated or whatever.
yeah, yeah,
Oh my God.
yeah, it's really horrible. And there's, you know, I know there's people that have like protested that, and apparently if you refuse to do the dog lab, you're risking your medical education. And some people believe that kind of a thing is not really to help teach you surgical technique. It's part of that process of, you know, cause, I guess, suppressing your emotion or compassion fatigue that, you know, that I mean, you know, the thing with cadavers, they could probably teach people anatomy without having dead people. I mean, I don't know, maybe it is helpful. I have some pretty clear memories of that gross anatomy lab, but I
Me
think
too.
yeah,
Me too, Mark. Yeah.
yeah. I mean, if any, I mean, actually, lots of them. I mean, one thing is, you know, remembering what the tendons look like, wow, that almost looks like artificial. That those arm tendons, and, you know, just, but yeah, that's between, you know, but even worse, going beyond that, just the way residencies are of these long shifts of 48 hours or whatever, you know, which are supposed to be limited, but they're not. And you just, the things that you see and the things you have to deal with, and the people who are superior to you tell you that you just have to do this or do that and not really feel anything. And you know, doctors just come out of medical school and out of residency, not really connecting, not having empathy for their patients. And it's just, I can kind of see how that, you know, that you just kind of, they might look down on a patient or not see them as a human being the same way. And, when a person says, I want to get off of this medication, and now you have a doctor who's been through all of that, and now they're working in a place where they have to see 50 people a day or even 30 people a day, which is still a lot. That all you're thinking, and I've worked in a place like that, when you walk in the room, all you're thinking is how can I get out of here? Because I have so many more people to see before lunchtime. And I have a bunch of charts I have to call people back and all this stuff to do. And then the person says, gives you this big problem. It's like, oh, I can refer them somewhere. I can order some labs and put off talking to them until next time. You have all these ways of dealing with it. But, people in this situation need help. And on top of that, you have these drug reps coming in the office, taking up time. And these drug companies, they really have no intention of people coming off of medication. And it's so easy to get put on a Prozac prescription or even benzos. I can't sleep. Well, here's some Restorel, which is a benzo, and that'll help you sleep. It's only meant to be taken for 2 weeks, but when you come back and tell me how great it worked, here's another prescription. I think a lot of benzo dependence happens that way. That it's easier just to write the prescription again and just keep it going, and people really do feel better with it in the short term.
Mm-hmm. Yeah, I mean, there is a physician, his name's Sammy Tamimi he's like a child psychiatrist in the UK. And he said once, like, he doesn't even like short-term prescriptions because he says that they open the door essentially for long-term ones. And I think that's true. It's like what you say, somebody maybe intended for something to be short-term, but then when it worked, the next doctor's like, oh, you got that? We'll just keep refilling it, or the same one. You come back and they forget that they intended for it to be only 2 weeks and they prescribe it longer because the patient says it worked. Or like what you said, just the problems like sort of baked into the way that our medical system here is in the US, like corporate medicine. I worked in it too before I got sick, and it was like even the place that I worked for would send us reports at the end of the month. Like, your average time with a patient was this many minutes. Your goal is to shrink it down to this, or your dictation was too long. And everything was about just compacting it in to shorter amounts of time and like, hurry up, hurry up. And they're monitoring you, about how fast you are. So how can you provide good medical care, And then a complex case like, oh, I'm physically dependent on 3 psychiatric meds at the same time, and I need like this taper plan written out for me and all of this. Like, there's no time for it.
Yeah.
Yeah.
I saw someone post something on Twitter that was interesting. I don't know, and it never occurred to me, but it makes perfect sense. Something, and I don't remember the exact wording of it, but something about that you'll never be taken seriously as a credible person ever again once you're on psych meds. And it kind of makes sense if you think about it. Imagine that someone is like say a witness in a court case, and then they bring it up like, oh, well, you're on Prozac, or you're on Xanax or Klonopin. Are you sure that we could, like, now it brings up in doubt into their testimony.
Yeah.
And doctors may see it the same way. Like if you start complaining about stuff, like, well, you're hysterical, you're making it up. I mean, you're imagining it. It's in your head because you're on this stuff already that affects your brain and whatever. I mean, it kind of makes sense. Like, and people should probably be aware of that as well. That came up recently with a family member of mine that was their doctor quickly offered them a prescription for Prozac because, just for being shy, really. And I happened to be there, and I said, well, no, why would you even bring that up? What does it have to do with anything? And the doctor looked at me and she smiled. She said, oh, do you think Prozac is addictive? And I'm like, well, no, but causes dependence. It's very difficult to get off of, and probably doesn't even work for a lot of people. And it's just, all it does is cause problems for a lot of people. And that's just one thing. I mean, all these drugs, psychiatric drugs and antipsychotics and things that cross the blood-brain barrier and affect the brain chemistry in ways that we don't know. And all these things, if you look at the FDA-approved literature, they all start with, we don't really know how it works, but here's how we think it works.
Yeah.
It's just crazy of what doctors unknowingly are doing to people, being pushed by the big pharma people. And yeah, these drug reps come in with these colorful pamphlets of like, look how safe and good this is, and it's going to help them with this, and they show comparisons, and the things that I think also are designed to make the doctor feel kind of dumb secretly. Like, you start thinking like, wow, I don't know what that, look at those P's and Q numbers or whatever these these statistical numbers that I never really learned that well, and they're comparing all these drugs and using terms I don't even know, and this person who's not even a doctor knows this stuff better than me. I mean, of course, they've been trained very well on that one very specific thing of comparing their drug to a couple other ones and a couple of studies that they know very well. And before you know it, they've convinced you that the best thing I can do is get this patient on this drug, and then they give you samples, so you can like give free samples out. Say, oh look, I happen to have a colorful little pack of them here, and I probably have enough to give you like more the next time you come in until they run out, and then we have to give you a prescription.
Mm-hmm. Yeah, and then that prescription will be so expensive because it's still on patent, which is why the drug rep is here promoting the drug in the first place, because they can get a lot of money from it because it's not generic, but
Yeah,
oh yeah, all of the problems that are just, you know, in our American medical culture that, creates these nightmares for people that I think a lot of people who go in are just unsuspecting patients. Like they blindly trust their doctors to know. That's how I felt. I mean, I had just finished PA school when I started psychiatric medications. And I think because I was fresh out of training by a bunch of doctors, and I really wanted to believe that like I had chosen a profession that was to help people, that everything I taught had been taught in school was true, and I was raised by a physician. And so I had that sort of in me already, like looking up to my father and thinking like doctors exact cures, they help people all the time. And so I didn't even have harm like on my radar at all. Um, Such a
yeah,
naive, stance, but that's really how I felt and thought. Like if a doctor says it must be so, and all they can do is help you. And now I realize
yeah,
that medical error is the third leading cause of death in the United States. And I was just so
yeah.
naive. Yeah. So,
That could be a big part of it for doctors also, that imposter syndrome where you feel like you don't really, and I think a lot of us feel it, like we just feel like we don't really know enough, and we're not as good as everybody else, and I think like the big pharma, I think, really preys on that, and also that. But yeah, like, so when you go into being a resident and then a doctor early on, you just want to keep up with everybody and do what everybody else is doing, and
mhm.
and and when you see like a doctor shouting at someone who's in withdrawal, saying, you addict, you're going to rehab, and we're going to put you in the psych ward and ship you out or whatever, however they say it. You're like, oh, that's how you do it. So when I see one of those cases, I'll know what to do on my, send them to rehab. That's how you handle that kind of case. Maybe make a note in your little pocketbook that you keep with you of
Yeah.
notes of what to do. But yeah, in a lot of cases, nobody's really questioning any of this stuff. But this is completely, I mean, as real as anything. That people, these drugs, these psych drugs, are benzodiazepines, antidepressants, can be very, very damaging to people and cause very long-term damage. And they have to be, people have to be taken off of them very carefully and gradually. And everybody's different. I mean, that's important. Also, patient-led tapers or patient-responsive tapers, where you don't like just say, here's your plan and we're sticking with it, and don't think that you're going to deviate from the plan. Sometimes a person is not ready to make that next reduction, and they need a little bit of time. Sometimes you have to reinstate. Yep. So everybody has to be looked at as an individual case, and in some cases, people have to work with their doctor, and I mean, to bring up also the idea of a tapering coach,
Mhm.
somebody who's not a doctor, but someone who has a lot of experience in this, who's done it themselves and has worked with other people and knows how to be and can be that advocate. Like we are talking about bringing somebody with you. Maybe someone doesn't have an advocate, and they can't be their own advocate, or they don't feel comfortable being their own, and they could call you, they could email you and ask for help.
Yeah. I mean, some people just honestly like the math overwhelms them, or just the idea of like using a syringe. Like they really need somebody to sit down and take an hour with them and kind of design a taper and then show them how to use the syringe and like what all the markings mean. And I mean, you can simplify it as much as if the person designing the taper knows the math, that the person doing it who maybe has cognitive impairment because they're on, 3 psych meds or something, they can just break it down very simply and say, okay, you're doing a microtaper and the math works out where you can come down by, 1 tick mark on this syringe every day. And you don't even have to do the math or think about the math. And like you said too, the tapers kind of have to be individualized. It's not like you can write one that's like a recipe and send somebody with it and say, follow this and you'll be fine. Because maybe the rate that you started somebody at for the first 6 months or something works really well. And then they get halfway down in dose, and that same rate doesn't serve them anymore. And it has to be slowed back because the current dose is much smaller now. So it helps to have somebody who, you can touch base with once in a while and say like, okay, how would we rework this now if I need to slow it down or that kind of thing. And then you can take that plan to your doctor and say, hey, I'm a really easy patient. I'm not going to take up a ton of your time today. Here's my plan. It's been working great. I just need to slow down a little bit. I need a refill on my compounded liquid and I'll be out of your hair. So
Yeah.
yeah, that kind of thing. But
Yeah. Doctors who are willing to work with you. I mean, it also does help to be, like say the doctor doesn't know how to write the prescription, um, for the compound. I mean, to even say that, I talked to the compound pharmacy. I found this great place. They're certified and whatever. They're a really good compound pharmacy. You can look them up if you want. And they sent me a thing of here's how you write the prescription.
yeah,
That they can just copy that right up and just fax it to this number and it'll be handled.
yeah,
Which is not that difficult to do.
yeah. And yeah, compounding pharmacies are great to really good resources. So if you think about it, they're filling all of these scripts for people who are using the compounded method anyways. Some people call the local compounding pharmacies in their area and say, what doctors are writing compounded benzodiazepine prescriptions? And then you get their names and you figure if they're writing for them, they're probably doing tapers. So you can call that guy, and see if he's taking new patients. So you can
Yeah,
kind of
that's a
work
good idea.
backwards, yeah, and see. You just have to know what you're doing and where to look, to try to get help with this. So, yeah.
Yeah. Yeah, that's a really good idea that the compound pharmacies would know.
Mhm.
And there's a actually I'm gonna look it up. I
Was
just
it
want to make sure I have the
the
for finding
PCCA RX one, you mean? The
oh
light?
that's it. Yes.
Yeah.
Yeah, what is that? There's that organization. If you Google them, you can find like the best compound pharmacies.
Yeah, it's called PCCA RX, and they
Yeah.
they monitor and certify compounding pharmacies, and they even have a link with like a little box that you can put your zip code in and do like a 10 or 20 or 30-mile radius, and they'll tell you all of the certified pharmacies around you that you can, reach out to.
Yeah. Yeah. I have the compound pharmacies that I like to work with, but I did that and found out that if I needed them, there's actually a bunch of local ones. I mean, they're everywhere.
Yeah.
So
There's even ones who work, like I use for some of the people that I work with Dr. Whit Daring's practice. There's one in New York that ships to tons of states as well. So if you're like in some rural place that doesn't have a compounding pharmacy, you can have one mail you your medication as well. So
yeah, that's true. If the pharmacy has a license in your state, it's as if they were there. Like
mhm.
we use one in North Carolina, but they have a Florida license, and it works just like as if they were in Florida.
Yeah.
We send the prescription, they send it to us, and it doesn't matter that they're not physically located here.
Yeah, exactly. So, yeah, I mean, that's where having a doctor like you who knows all of this stuff, or a coach who's been in the trenches working with people, like these are the tips and tricks and things that you need to know in order to, if you're, using a compounding pharmacy, they also know like what concentrations they can make for you if they're making a liquid, like the smallest amount per milliliter they can make, or if you're doing compounded capsules and you're going down from one to the next in dose, they can tell you, all right, here's with precision the size of reduction that we can get that's the smallest. you know, if we're doing it for you, weighing it on a scale. So big, you know, resources just in talking to a compounding pharmacist. Yeah.
Yeah, definitely. Um, yeah, that's and now in the book that you're talking about, that deprescribing guide,
Hmm.
they also have we talked about this before, there's even instructions for people that for whatever reason might not have access to that, you know, say in the case of a person that goes to their doctor and the doctor is willing to keep giving them a prescription, just say for Klonopin, and they're like, here's your Klonopin prescription, and maybe the patient knows if I say anything, they're gonna label me as an addict or something, and refuse to give me the prescription anymore, and they just have to they're not going to be able to get the compound prescription.
Hmm.
um, and so I think you told me that book does talk about ways to do it on your own if you really have to. Not that I'm recommending that at all, but
Yeah.
if a person had to, that like a lot of these tablets are very soluble in whole milk.
People use whole milk for Klonopin and Valium all the time, and it works great. Yeah. Um, and they use it, I mean, they use whole milk too for other things because milk is sort of, it's more viscous than water. So even if you're using a drug that isn't water soluble, for example, um, you would be getting like a suspension because it's, you know, it's like the snow globe thing. If you can picture a snow globe, if it's just water in there and the flakes and you shake it, the flakes are going to probably fall pretty quickly in water. But if you put something thicker in there, like maybe water mixed with sugar, you know, they will stay up longer. And so that's what people are trying to accomplish with using milk instead of water sometimes. Sometimes people even buy their own like Aura Plus and Aura Sweet and make their own suspensions at home.
Yeah,
But a lot of people, you know, will just take Klonopin and put it in whole milk or Valium and put it in whole milk, and they'll do their own at-home liquid emulsion is what it is called when you do that. And that there's citations in that Maudsley book for why milk works for those two benzos specifically. Like that someone actually had done a study that shows that milk would be a good
yeah,
liquid to use. Yeah.
that's for Valium. What was the other one besides Valium?
Klonopin. Yeah.
Klonopin.
And then some people dilute the manufacturer liquids down as well with more water because some of them are very potent and you don't want them so potent. You want them more diluted so that you can make smaller cuts. And so people will get like Valium liquid, for example, comes in 1 to 1, which is a pretty good ratio. But if you wanted it more dilute, you know, people just add more water and maybe they make it 1 to 20 or 1 to, you know, 50, whatever they want it to be, essentially. And then they kind of micro taper, changing it in that way. So yeah, that book tells you all of those methods as well. Um, and maybe it helps to show your doctor that if that's the method that you're going to try, because a lot of doctors will get weirded out about that. If you tell them you're at home and you're like mixing up your Klonopin with whole milk, they're probably going to look at you like you're crazy, or what are you doing? That's so dangerous. Or, you know, you're some drug addict, obviously, because you're making like a milk drug concoction, you know. But it really is a way that is a means to an end to successfully, gently peel yourself off of these drugs, you know. So
Yeah. I would imagine with the milk taper, you'd be also restricted by the expiration date of the milk. That you wouldn't want to mix like a large batch of it all at once, probably.
yeah, people do it every single day for their dose. Yeah, they don't store or anything like that typically when they do that. Yeah.
Yeah. I mean, I think it's great that there's resources for people at all levels. I mean, not everybody has access to, you know, that they're in wherever they happen to live, you know, and that not everybody has access to a doctor that's going to help them through this. So there's you know, it's good that everybody has can get the information they need.
Yeah.
Um, you know,
Yeah,
I
and
think it,
compounding is expensive. You know, it's not cheap
yeah,
to get your drugs compounded, especially if you're using pure powder versus the compounder just crushing up tablets for you. Pure powder is like, you know, 70 to $200 per like month of liquid. It's very expensive.
yeah, yeah, and benzodiazepines tend to be very inexpensive.
Hmm.
Uh, I mean, unfortunately, the generic tablets can vary in their potency because they're not always exactly what you think they're getting. They
Yeah.
can vary by whatever 20-25%. But at least there's a lot of resources that people can, whatever situation they're in, they can figure out some way to do the taper.
Yeah. Yep, exactly. And even if all you just have is water, people are doing water titrations all the time. And maybe it's not the most ideal because of that, again, that snow globe thing. But it doesn't mean that people aren't successful using water titration all the time. They are, if you just come in the groups and have a look around, you'll see. And my opinion is it doesn't matter how you get off of this stuff. If it works for you, then it works. Like it's a means to an end. And that's, you found a method that works and congratulations. Now you're finally off of this drug that you wanted to be rid of. So
Yeah. Yeah. Speaking of that, there's lots of different, people want to always know, like, what can help them along with just, the tapering. So that they're doing the tapering, they're doing gradual reductions of their medication.
mhm.
And then, what else can they do? Of course, eating healthy, exercise, eating less refined foods and less sugar, that's all good. We talked about that, of even like a ketogenic diet being helpful in some cases. Um, and then also, as far as supplements, that's kind of a complicated thing because some people will have really terrible reactions to certain supplements, and some people will have a lot of relief from them depending on the supplement. For example, like I've had some patients do well with that L-theanine, which helps them to relax and get to sleep and focus, and it has like various benefits, but some people might have a bad reaction to it. Same thing with other things like antihistamines, and some people might do great with them. There's the antihistamine for anxiety that helps some people.
Visceral, you mean?
Yeah,
Yeah.
visceral. Yeah, so
Mm.
that for some people that in fact some people have had experience where they might have a terrible reaction to it. And they're like, oh, how can you even think to recommend that to me? But it does help some people.
Mhm.
Um, and the same thing with probably like magnesium, and there's different kinds of magnesium. Some are better than others, and some might be helpful, and then some people might have a reaction. So say, everybody's different. You have to be careful. Maybe try a little bit of something, and if it doesn't work, if it, don't do it again. And, but that doesn't mean it's not going to help somebody else.
Yeah, it's true. I mean, we have a list at benzoinfo.com of all of the things that people have written into us over the years saying like this caused me a horrible adverse reaction. Probably because when people are in withdrawal from psychiatric medications, their nervous system is destabilized in some way to where they don't respond to other agents in the same way as they would if they were a healthy volunteer. But we don't know. I mean, we really don't know why people are having these chemical sensitivities, but we know that it happens, at least anecdotally. We have tons of reports of things even people tolerated when they were well, they don't tolerate now that they're in psych med withdrawal. And so, yeah, all you can do is kind of mitigate risk, which is, start low if you're going to try something in tiny little doses and kind of test it out and see. You can look around at anecdote and see, well, are a ton of people having problems with this? If so, it's probably more risky. You can look at kind of the suspected mechanism of action of the thing, even although with supplements it's hard because they're not as studied really in some instances. But if it messes with GABA and dopamine and serotonin, it might cause you issues because that's the system that you're kind of trying to heal or that's damaged when you're in psychiatric drug withdrawal. And then, as with anything in medicine, it's a risk benefit analysis. I mean, I ask people who ask me that question all the time. You have to say, like, how bad is the thing that I'm having that I'm trying to take something for? Can I live with it? Or is it worth the risk of introducing something that I'm hoping would help, but I don't have any evidence that it's going to? And it could make me worse. Can I deal with being worse? And then you have to make that hard decision of if you want to try something. In
Yeah.
general, I've not heard a ton of success stories from people introducing a supplement and saying like, it healed my withdrawal. If
Yeah,
anything, they kind of like mask or give minor kind of relief. And so, like, if you're expecting a magic bullet, it probably doesn't exist. You may get something that kind
yeah,
of gives you a little relief or allows you to keep going. But ultimately, I tell people the best tool you have to control the severity of suffering in most cases is the rate and speed of your taper. And
yeah,
finding out this information before you make big mistakes. Like that is kind of our challenge at BIC and everywhere else doing this work is how do we reach people before they start tapering their drug with bad information? Because that's when people get
yeah,
injured and really, really sick. Like if we could catch everybody right before they make that catastrophic mistake of listening to their doctor who says, cut it in half. And then, because once you've injured the nervous system, sometimes it doesn't, like reinstating the drug doesn't fix it. People are kind of left with symptoms that they, have to live with essentially until the nervous system heals. So, but I don't know. I've
yeah,
not cracked the code on how to catch those people first. That's
yeah,
usually how people even figure out they have a problem with the drug and physical dependence is they make some big mistake and then they're like, oh my gosh, what is this? So
yeah, yeah. Sometimes when you you know do like if I do a consultation with someone like because we do like these paid consultations where someone it's kind of like a patient visit, but it's not a medical visit. It's just to like share information.
mhm.
And I sometimes feel like I hope I can give them something useful. I hope I can give them their money's worth. I don't want to like talk to someone and maybe not really give them anything useful. Like but I do my best try. But when you can tell someone if they say like I was thinking about going to a rehab or a 2-week
Yeah.
detox. I'm like, oh, okay, I can give you your money's worth right now. Just
Yeah.
stay away from that.
Please
Don't
do
do
not do that.
that.
Yeah. Yeah. That's
Yeah,
worth, so much because the rehab is going to rob you of thousands and thousands of dollars. Those places are not cheap. And
yeah,
then all of the fallout. I mean, I've never sat down because it would probably be too depressing, but like added up what that decision cost me as far as like the amount of money I would have been making every year if I was healthy enough to work and like investing in a home to have a mortgage almost paid off and all of these things that you could add up over time because I was sick I was out of work from 2010 until, only recently did I start working again from the injury just because I made the decision to go to a detox center. So it can be a huge cost to people financially and socially. I mean, people can lose everything. Everything.
yeah, yeah.
Yeah.
So some great advice we can give people right now. If you're listening right now, don't go to rehab or
Yeah.
detox. Get that book that deep. Is it Mosley? How do you spell that?
Maudsley,
Mosley.
Maudsley, deprescribing guidelines, and it's on Amazon, probably wherever books are sold, I think, but just Google it and you'll find it. It's purple. Yeah.
Yeah, yeah. And if you want to even save that, for if you don't want to spend any money, go to benzoinfo. Is it benzoinfo.com?
Mm-hmm. Yeah.
And or Google the Ashton manual, and the first thing that comes up will be the PDF that's free offered by benzoinfo.com, and you
Yeah.
can get this incredible great resource. It's almost like the Bible. It's not perfect. It's not just like no Bible is perfect, but it has, if you read it, like every time I read it, I find something new. I'm like, oh,
Mm-hmm.
she really didn't say. People say like, well, Ashton didn't do it the right way, and I'll go back and read it. And I'm like, well, she never really said the things that you're all saying she said. It wasn't a one size fits all. She didn't say you have to do it this way. It's a guideline. It's something that you can use, and it was, it's a major, incredible first piece of work, based on decades of research of hundreds and hundreds of patients that without it, that's the foundation really for everything. And
Yeah.
that's what got me into this originally. I've been doing addiction treatment for a long time, and I started hearing Ashton Manual. Like, have you heard of the Ashton Manual? And I'm like, no, but I'm going to go look it up now. And just sometimes just like that, hearing the words, the right person hears it and they go look it up and like, wow, this is like a whole world I didn't even know about.
Yeah, exactly. Well, thanks for being one of the doctors who is willing, because most of them say, Where'd you find that online? I'm not going to read that, but yeah, here she is, some credible psychopharmacologist in the UK who's put this beautiful manual together to try to guide clinicians on how to help their patients. But you're right. The most important sentence in that manual, a lot of people ignore, which is this is only a guideline. Like it's not meant to be followed as a strict recipe. It needs to be tailored to each individual patient, et cetera. But that's the problem with guidelines. I mean, there's a guy, I don't remember his name, but like his whole uh focus in all of his work is like the problems with guideline based medicine, because that's what doctors want to do is like follow a guideline sort of to a T. And they're so problematic. I mean, I'm figuring that out now. I'm on the committee working with the ASAM, so that's the American Society of Addiction Medicine, who they just got $2 million in grant money from the FDA to come up with deprescribing guidelines for benzodiazepines. And they have a patient panel, which I'm part of, and then they have an expert panel. And they've just given us the first cut, if you will, of what their guidelines are going to be. And all of us on the patient panel are like, go back to the drawing board. Like, this is not it, because we know doctors are going to read this stuff and they're just going to follow it, like without long explanations of things underneath of it. I mean, some of them were just dangerous. Like, well, if somebody's having too hard of a time, then they can go to an inpatient center. And we're like, no, they can't. I mean, that, so they're trying to put things in that we are like so opposed to. So anybody listening, pay attention because soon, I think like June or July this summer, sort of the first draft from the ASAM is going to come out. And what they do is they make it public and then it's open to public commentary. So anybody kind of vested in this topic who wants to have your say, you're going to have like 30 days or something to go leave, um, points underneath of it of all the things that you are opposed to. And then we hope that they take some of the feedback and actually incorporate it and come up with, I mean, I'm not super hopeful. I'm trying to, hope that we get something that's decent. I'm not expecting it to be perfect, like something that I would write or you would write, Mark, but I don't think we can hope for perfect in this. We can just try to influence it as much as possible, but these are
Yeah,
going to be the official guidelines that are probably going to be followed, you know?
yeah.
So,
And just so people know who the ASAM, who they are, they credential doctors. A doctor who's board certified in addiction medicine may have been credentialed by that organization, but they also advocate 12-step facilitation as being a evidence-based therapy for addiction. Not the 12-step group itself. So if you go to AA, there's no way that nobody can really do a study to show that AA is a evidence-based medicine, because it's a group you go and you do the 12 steps, which involve believing in a higher power and praying to have defects removed or whatever. I'm probably not saying it precisely, but
yeah,
so
surrendering and all of that, right? Yeah.
yeah.
How do you measure that?
So imagine a medical organization that credentials doctors to allow them to be board certified, that advocates prayer as being a medical therapy. I'm sick. I have a medical problem wrong with me. Pray that you're broken.
Yeah.
You have defects of character. Something doesn't feel right about that. So that I take it with a grain of salt, whatever they come up with.
Yeah.
And it's unfortunate that 2 million didn't go to Benzo Info to BIC to do this work.
Yeah. I mean, the existing nonprofits in this space that work on this, I mean, there's two of us. It's us, BIC, and then there's another one, the Alliance for Benzo Best Practices. But when we saw sort of the requirements to get the 2 million in order to make this thing happen, it was like way too much and tiny little grassroots organizations could have managed on our own, to meet the criteria of what they were looking for. And so unfortunately, a big kind of mainstream organization like you're talking about with major problems is the one who was awarded the money. And now we're just the patient panel that, I don't know how much they're just kind of blowing smoke and pretending like they care what we think because they have to sort of check that box and say, yep, we had a patient panel, you know, but I don't know. I mean, they have admitted that they did like a huge literature search and that the literature is like completely lacking as far as benzos and how to effectively get people off of them. So, I mean, at least we know that and they're admitting that, but what are they going to come up with the final recommendations is what is kind of yet to be seen. So, keep your eyes out. I mean, Bic will be advertising it all over when it's ready for public commentary. And we hope that like they'll just be bombarded with the same message over and over again if they have a very potentially damaging recommendation, like send somebody to an inpatient facility, you know?
Yeah, yeah, which I can see that maybe being a part of it. That there's always that thing where people want to cover for themselves of saying, I'm not going to take any chances. I'm just going to refer you to
Mhm.
inpatient, to the psych ward, to the that, which can be very harmful to
Yeah.
people. So yeah, it's this is a real thing, but we have a lot of big forces against us. Big pharma, the like we were saying in the addiction treatment community, the rehab industry, the how Alcoholics Anonymous and the 12 steps are very entrenched in that, and it's just not there's just a lot of um, major big forces of things working against getting this information out. And but it is a real thing. In other countries, sometimes we have to look at what's going on in other countries. For alcohol treatment, there's a Canadian organization. I think it's the Canadian Alcohol Use Disorder Society, and they have incredible information about medications that can be used for alcohol harm reduction, getting people off of alcohol. And that information is just not readily available in the U.S. And they're not that far away. I mean, just apparently everybody, 90% of the population of Canada lives along the border, so they're practically in the almost here anyway. But they're so advanced in some of this addiction stuff. But we have too many of these forces in our country that are working against suppressing or not making that kind of information readily available. And like you said, a lot of great work is coming out of the UK. I think they see benzodiazepines a lot different than we do. And so you have Dr. Mark Horowitz working there. We had Dr. Ashton. There's just so much. So sometimes we have to look to these, advanced countries, that are maybe more advanced than us in a lot of ways, and to get the best information.
Yeah, it's true. It's kind of mind-blowing, isn't it? Like what you're saying. It's just literally like across the pond or across this border and it's so different. It's like how it's the same chemical and we're all human beings, but you over there recognize the harm and we over here still are like in the dark ages and not understanding. It's crazy to me, but it's true. Yeah.
Yeah,
Yeah, Dr. Horowitz says all the time, like you US people are crazy. Like when he looks at our numbers of benzo prescribing, compared
yeah,
to what they do in the UK, he's like, it is wild over there in the US. And I'm like, yeah. So
yeah. It's
I
hard
think
to believe.
universal healthcare helps a lot too. And I'm sure I'll get comments about, some political thing or whatever. Obviously there's good things and bad things about all things when you're making an argument. So I'm not advocating for one thing or another, but it's easier when you have a healthcare system regulated by the government or whatever to say, okay, you can only prescribe benzos for 2 weeks. And then that's the rule. And everybody has to follow it because that's, like the NHS can make the rules. Whereas in the US, you just sort of standard of care is using things off label and whatever. And even in different states, the rules vary. I mean, I think in Tennessee, gabapentin is a scheduled drug, but in another state, it's not. So it's kind of the wild,
Yeah.
wild west over here in the
Oh
US.
yeah, yeah. I mean,
Yeah.
you can. I mean, just your healthcare system is broken when hospitals are successfully suing patients because they can't pay for their hospital bills. It's
Yeah.
one thing to send them to a collection agency, but it actually happened to me. they actually got to experience that during early in COVID, the process server coming to serve us with papers of being sued by our local county hospital for not paying a bill on time. And the guy just kept knocking. I finally called my own healthcare lawyer, said, what do I do about this? He said, it's not something we deal with, but he said, I actually went through the same thing myself. You just got to pay the lawyer and they'll go away.
Oh
And
my gosh.
but that was a relatively affordable bill. I could afford to pay it, but there's people that are being sued by hospitals for bills that there's no way that they can afford to pay, and they're being taken to court and sued successfully by the hospitals that they went to for medical care.
Yeah. Well, welcome to America. I don't know.
Yeah,
Yeah, it's just it's broken over here. Our whole system is broken in so many ways. And unfortunately, it's the patient that suffers most of the time from that, you know?
yeah,
So,
definitely something. Yeah, something's got to change with that.
yeah.
But yeah, Nicole, thank you again. Thank you for this incredible conversation.
Yeah. Thanks for having me. Talk soon. Bye,
Okay, thank
everybody.
you.
Thanks for listening. Yeah.
Bye. Thank you.